Good morning. Thank you for joining us for Grand Rounds, St. Luke's Physical Therapy Grand Rounds for May. This is a wonderful social distancing time, so we're doing this in recorded format. Today, we have Dr. Jeremy Kushner, who is the facility director at our Nazareth office. He graduated from Misericordia University with a Bachelor's of Science and a Master's of Science degree in Physical Therapy, and then earned his Doctor of Musculoskeletal Physical Therapy from Evidence in Motion, which is while at EIM. Jeremy also obtained a manual therapy certification, and he is a board-certified orthopedic specialist in physical therapy, and he practices at our Nazareth office. So without further ado, I will turn it over to Dr. Kushner.
Dr. Kareha, thank you for the introduction. Today, this presentation is going to be primarily on how manual therapy works from a literature perspective. And this topic really enlightened my thoughts on manual therapy because it confirmed my skepticism towards certain biases and explanations I learned in school and continuing education courses. And I hope this changes your thought process towards manual therapy. This is the activity description. This is St. Luke's Designation Statement. I have no financial relationships to disclose. And here are my learning objectives. My goal is for you to learn the comprehensive model of mechanisms and how manual therapy is effective as it relates to the literature, to demonstrate the ability to explain manual therapy in clinical practice, to increase the usage of manual therapy in appropriate clinical situations, to understand the pitfalls of the traditional biomechanical theory of manual therapy, and to describe the cascade of neurophysiological effects that occur in the peripheral and central nervous system with manual therapy. So when we think about understanding mechanisms, why does it even matter? We understand that manual therapy is a very effective tool at treating musculoskeletal pain. So the argument is, does that even matter how we know it's effective? And the answer is yes. And the first reason that I would bring to attention is physician underutilization. Physicians really underutilize complementary and alternative medicines. There's one particular study that polled physicians, and roughly 50% of physicians reported that understanding the mechanisms of a certain treatment is influencing the decision to refer for that treatment. And patients are less likely to seek intervention without their support from the physician. So the better the understanding of manual therapy, the more referrals we're going to receive. Secondly, we want there to be more appropriate provision among manual therapy providers. And finally, we want more effective use of manual therapy. We understand that many PTs underutilize manual therapy, even from a joint-based model. Not many therapists are using thrust mobilizations compared to non-thrust, and there's certain times that we may want to use those techniques. So when we think about manual therapy as a whole, this is clearly not an exhaustive list, but from a day-to-day perspective, we are providing really three different types of techniques. We could do a joint-based model where we provide a thrust or non-thrust mobilization. We could think of it from a soft tissue perspective, where we're doing instrument-assisted soft tissue mobilization, any type of massage, myofascial release, cupping, or trigger point release. Even dry needling would be on this basis. Or neurodynamic mobilizations where we're providing sliders, gliders, and tensioners. Most of the literature that I found for this presentation tend to be heavily studied towards a joint-based model, but the researchers argue that the effectiveness of manual therapy is almost similar on all three, because the reason for the effectiveness tends to be more driven by the nervous system the central nervous system in particular. So when we provide any one of these techniques, we're actually having a profound effect on the nervous system and at the local area. So how does manual therapy work? This was a really interesting article that was published in JOSPT by Joel Bialowski and his team, where they've done probably the most research regarding how manual therapy works. And they gave us a case example where a patient who had focal low back pain was evaluated by a physical therapist. The physical therapist noted no contraindications to the use of thrust mobilization at the lumbar spine. And the patient had significant improvements after 24 to 48 hours. And the patient asked the therapist, how did that make me better? And among many manual therapists, anyone who's listening to this who utilizes manual therapy, there is really not a universal answer to this. This is very challenging because there's a lot of different providers that will use manual therapy, and there's the answers are endless. But more frequent than not, I hear therapists utilize a biomechanical approach to explanation, where you could say, well, you had a facet restriction in your back and we loosened it, and that's why you're feeling better. Or I've even heard we realigned the pelvis, or you had subluxations in your spine and we made your spinal column more aligned. So this is what we would consider a traditional correction philosophy, if you will. So this patient experienced diminished low back pain with manual therapy and wants to know why. Well, you may have identified and then corrected the innominate. So if there was an anterior or posterior rotation of the innominate, you may have identified that there was some type of torsional rotation on the pelvis, and you performed a muscle energy technique that made the innominates more symmetrical. Or you may have identified the opening or closing restriction in the lumbar spine and then corrected it. So if something wasn't opening and they had an opening restriction, you performed a gapping technique at the lumbar spine, and now they're moving better. So this is primarily a correction philosophy. And I've even heard explanations of subluxations, spinal alignment, or faulty positions, or when we think about a soft tissue perspective, when we're performing instrument-assisted soft tissue mobilization, breaking up adhesions, if you will. So this, again, is the correction philosophy. And the reason for effectiveness under this philosophy, one, we know that manual therapy causes a reduction in pain when we provide it. So therefore, we must conclude that manual therapy causes some type of correction, and this correction equals a pain relief. So we're going to kind of debunk this myth and look at the latter two here, manual therapy and the correction, and correction equals a pain relief from a literature perspective. And I'm going to give two examples of different studies or pioneer studies that really look at how that doesn't occur. So the correction philosophy has significantly influenced our profession so much that it's not often questioned, and it's been perpetuated because manual therapy is such an effective form for pain. So I believe the big question that we have to answer is, has the effectiveness led to a false assumption on how manual therapy works? And the literature would argue yes, it does. So this traditional biomechanical approach is heavily anatomically emphasized, right? Our assessment is based on positional faults, passive intervertebral motion assessment, and palpatory assessment. And then these treatments are directed towards these anatomical faults. And there's numerous treatments towards these anatomical faults. And then our education tends to be more biomechanical effects. And what we're understanding is that this is not an entry-level skill. And I think this is where a lot of younger clinicians, including myself at the time when I first graduated, I really didn't want to get into the higher level skills of manual therapy because I couldn't really feel what my mentors were feeling. But what we're understanding is that these type of examination techniques are quite antiquated and unreliable. So biomechanical explanations are still widely accepted today and taught in entry-level DPT school, but the literature just does not support their validity. So this is an older study, but I feel this is a really appropriate and what I would consider a pioneer study in our field of physical therapy, where Tullenburg and his colleagues took 10 patients with unilateral low back pain, and they were all examined by experts to confirm an SI joint dysfunction. All of these patients then received some type of mobilization or manipulation at the SI joint, and then they measured pre and post SI joint positions by what's called RSA. RSA is radiostereometric analysis. And what these researchers did was they injected little metallic tantalum beads into the innominate and the sacrum, and they took an X-ray. So you could actually detect joint position. It's a very accurate way of being able to detect how much joints move. And the interesting thing, if you could see this slide here, that pre-manipulation, most patients had positive clinical findings. So if you look at the left-hand part of the screen right here, these are all the tests that they did. And they're different names than what we currently utilize, but really they're just tests of provocation, tests of symmetry, and really tests of motion. And if you look at all of the patients from patient 1 through patient 10, most of them had positive findings before the manipulation, and most of them had negative findings after the manipulation, right? So the therapists that were providing treatment to this to the patients really thought there was going to be a significant effect in terms of joint position, because they had positive findings before, negative findings after. So they thought that things would be more symmetrical, or changes would occur between the innominate and the sacrum. But what they found was that there were no RSA values above accuracy. There were no statistical changes in movement. And this is not the only study that demonstrates this concept. There's many other studies that demonstrate this concept. So we could really understand that manual therapy doesn't really equal a correction of joint position. Here's another pioneer study done by Tim Flynn and his colleagues in 2002, which ended up being the derivation study for the lumbar spine clinical prediction rule for manipulation. Here they took 75 patients with low back pain. All patients received manual therapy targeted at the SI joint. And then they looked at the outcomes and found certain predictors of success. And here, again, they were unable to show any acceptable accuracy for any individual test proposed to identify an SI joint dysfunction. This is probably a little bit more updated in terms of how we use SI joint tests, special tests, if you will, where we're doing tests of provocation, motion, and symmetry. And again, they're not finding any specific test correlating with why someone would benefit from a manual therapy technique. But what they're finding is specific characteristics of patients who respond favorably. And really, from a pragmatic standpoint, we could argue that if a patient has low back pain and it's acute, so if it's really less than 16 days and there's no symptoms distal to the knee, these patients are going to really respond positively to a mobilization at the lumbar spine. Now, prescriptively, there's also low fear avoidance, at least one segment of hypomobility in the lumbar spine, and hip internal rotation greater than 35, along with the acuity of pain and symptom location. But I utilize more so time, onset of pain, and symptom location as being a more pragmatic approach to this. So the results of the literature towards this traditional biomechanical approach show really that manual therapy is not specific to an intended location. It tends to be more of a robust and widespread effect. It varies greatly from clinician to clinician. We know that some therapists prefer the use of thrust, some therapists prefer the use of non-thrust, and some really challenge that and do more of a muscle-based treatment. When we think back to the Tullenburg study, they do not result in any measurable change in joint position. Although joint motion did occur, and we're going to talk about that, there was no measurable change in position before and after the technique. And specific technique or cavitation does not influence the outcome. And we're again going to get into some more literature on how the specific technique doesn't really matter in terms of immediate pain reduction or range of motion improvements. So then what does the literature say regarding manual therapy? We understand that it does have a hypoalgesia effect towards it. And the reason for this is there is a biomechanical stimulus that occurs with our hands that actually initiates a multitude of what's called neurophysiological effects. So here is a list of neurophysiological effects that occur with manual therapy. And in summary, these could be a little bit confusing for those who really aren't well versed in neuroscience, or they haven't really studied that in a while, or when we think about our neuroscience back in DPT school. But there is a direct effect on the central nervous system. So when we provide a manual therapy intervention, functional MRIs show us there are changes to the central nervous system and the spinal cord. And this is where a lot of the changes occur when we provide any type of manual therapy for a patient. There's also increased afferent discharge. So basically what this means is there is pain modulation at the level of the spine when we provide manual therapy. And we're really, when we think back to the gate control theory of pain, we're lessening nociceptive input to the brain by stimulating other nerve receptors, if you will. There is motor neuron pool depression. There's actually changes to the alpha motor neuron. There's changes in motor activity that occur where when you provide a technique, you could actually improve muscle function and actually increase strength, if you will. There tends to be a decreased resting EMG activity after a manual therapy intervention. And I think the most interesting thing is reduction of temporal summation. Okay, temporal summation, this basically means a reduction in pain perception in response to a standard stimulus. Temporal summation is very important in the development of central sensitization. So we could really provide, I guess, lessen a chance of someone going from an acute pain perspective to a persistent pain by providing manual therapy for that patient. So this is the comprehensive model of mechanisms, which was published by Joe Bialowski and his team. And this is his interpretation of how manual therapy works and the mechanisms behind its effectiveness. And we're going to break this down into really three pathways that occur. I know this is a really busy slide. So the first is the mechanical pathway. There is a mechanical stimulus that we use with our hands provided to the tissue that results in a decrease in spasm and an improvement in range of motion. And then we're going to look at the spinal cord and how there's spinal cord mediated effects. There's changes to the peripheral nervous system as well, where there tends to be a reduction in inflammatory mediators. There tends to be neuromuscular responses that I just kind of went over, these neurophysiological responses at the spinal cord. And there tends to be a robust hypoalgesic effect. And the researchers are able to detect this based on functional MRIs and imaging. And finally, probably the most confusing is the supraspinal pathway, or what happens at the cerebral cortex in the brain. And this is really hard to study. But again, functional MRIs have given us the ability to detect how much uptake or reduction in uptake occurs with our interventions. But then there's also non-specific effects that occur with manual therapy, such as a placebo effect, or really what we would think about an expectation or conditioning. There is psychological measures that would change the way manual therapy works, such as fear, catastrophizing, and kinesiophobia. And then there's an actual opioid response in our brain that there's a profound endocrine response when we provide some type of technique to a patient. So again, this is just summarizing what I just spoke about. We're going to look at a mechanical pathway, a spinal pathway, and then a supraspinal pathway as it relates to the effectiveness of manual therapy. So here are some primary questions we want to answer as it relates to a mechanistic pathway. We understand joint or even soft tissue or nerve motion occurs when we provide a technique. So we want to know what type of motion occurs and are they specific and localized. So Herzog and his group studied both manipulation and mobilization at the lumbar spine. And if you could see here at the left side, they give us the schematic representation of this force time continuum that occurs, where we could clearly see at this peak force, there is a lot more motion here than at the resolution phase. So there is a lot of motion that's occurring whenever we provide a manipulation to a specific area. And then when we look at a mobilization, we can clearly see that from a posterior to anterior view, there's quite a bit of translation as it relates to millimeters of motion. And there's sagittal degree rotation that occurs when we provide posterior to anterior mobilizations to the spine. So are the forces specific? Kim Ross and his colleagues, they took 64 healthy participants. Each of these participants received a thoracic and lumbar spine manipulation. And what they did is they placed 6 accelerometers on different areas of the spine, and these accelerometers are used to detect vibration. So they could get a sense at where this cavitation is occurring when they provide this technique. And the interesting thing is that all the targets tend to be nonspecific in nature. Less than half of the lumbar cavitations occurred at the intended anatomical level. Slightly greater than half of the thoracic cavitations occurred at the intended anatomical level. Most procedures with multiple cavitations resulted in at least one cavitation emanating from the target level. So really, I think the decision is to move it and move on rather than specifically localize it. And I think the decision to move it and the decision to assess it is primarily how this intervention is going to be effective for your patients. So in summary, from a mechanistic pathway, we understand that biomechanical effects occur. They tend to be only transient in nature. They're not lasting long. So we know that these effects don't really last longer than 20 minutes or 5 hours. So if we were to provide a lumbar spine or thoracic spine mobilization, we could appreciate the improvement in spinal motion when we reassess it. But most of the literature shows that it tends to be only 5 minutes to 10 minutes of an effect after we perform something, but it could last up to 5 hours. So this is where we would really want to provide an augmented treatment or exercise program for that patient so that we could get better improvements in motion and make patients more reliable in modulating their own pain. There tends to be no lasting structural changes that occur. When we think back of the Tullenburg study, although there was joint motion that occurred, there's no lasting structural changes. The techniques are not specific in nature. So when we provide mobilization at the lumbar spine, if we even provide a posterior anterior mobilization at, say, at L5, there's movement that's occurring all the way up into the thoracic spine. So there's quite a widespread application. It's not precise. And our research is showing that clinicians are unable to reliably determine the specific area that would require treatment. Okay, so this is the second pathway and the reason for effectiveness of manual therapy. And this is probably where most of the literature is housed. There is a profound effect that occurs at the level of the spine, at the spinal cord. So when we provide even a peripheral joint mobilization or soft tissue mobilization, yes, there's an effect that happens at that area, but the result of it tends to be because of what's happening at the central nervous system in the spinal cord. And we're going to particularly look at both the peripheral nervous system and what happens there at the local tissue, and then some of these other neuromuscular responses that we talked about. These are primarily neurophysiological effects. There is hypoalgesic effects, which basically means a reduction in discomfort and pain. And then we'll talk a little bit about the endocrine system as well. So at the peripheral nervous system, we could appreciate that musculoskeletal injuries, they induce an inflammatory response immediately. There are inflammatory mediators and peripheral nociceptors which initiate the healing process. So cytokines and prostaglandins, whenever you injure something, really migrate to that area. And there are peripheral nociceptors in the spine that, like substance P and glutamate, which heighten someone's response to pain. So that it basically gives them that alarm to stop doing things, if you will. But following manual therapy, there has been studies that show blood serum levels show a significant reduction in cytokines and substance P, and an increased level of beta endorphins and endogenous cannabinoids. So if we have a reduction in inflammatory mediators and peripheral nociceptors, but an increase in our own endogenous opioid system, we could appreciate that there's going to be a pretty profound hypoalgesic effect that occurs as it relates to the spine and the local tissue. There is direct evidence in animal studies of how manual therapy works. So this one particular study, the researchers injected capsaicin into rats, and then they measured the activity of the spinal cord on functional MRI. So capsaicin really is a spice. It acts as an irritant, and it showed increase in uptake on functional MRI in rats in the dorsal horn. But following manual therapy, there has been a significant decrease in activity in the dorsal horn in the spine. And this is where we would say that there's inhibition of pain at the level of the spinal cord. So if we think about neuroscience and what occurs at the dorsal horn, this is where a lot of sensory neurons are. And if there is a decrease in sensory neurons, we can appreciate that there is a really hypoalgesic effect that occurs at the level of the spine. So a decrease in activity would result in a decrease in pain. And then there's a lot of literature, and this is again not an exhaustive review, of indirect evidence. And I already alluded to this before. There is an increase in afferent discharge, which basically means we're stimulating mechanoreceptors. So again, I try to explain this as the gate control theory of pain. If you stub your toe, you're going to get a nerve, an action potential through that nerve, and then the brain will be alerted to what happens. But if we rub the toe and we stimulate other receptors other than nociception, we can modulate that pain and modulate the perception of pain at the spine, at the central nervous system, at the spinal cord, and the brain. There tends to be a depression of motor neuron pool excitability. So there's changes to the motor neurons at the level of the spine. And then in terms of muscle activity, there tends to be a reflexive increase immediately, and then a decrease on resting EMG. So muscles, this would be where we're facilitating muscle relaxation with our technique. And some studies show that there's improved muscle function when we ask the muscle to move. not reflexively, but we ask it to move, it moves better. And again, temporal summation, there's a reduction in temporal summation. And this is really that inhibition of windup and pain perception that occurs. Again, very important in the development of central sensitization. Along the same spinal pathway, we talked about manual therapy improving muscle function. So I just wanted to pull in some examples of current literature that shows how it does, how it pulls, how certain mobilizations can improve the ability for the muscle to contract or really reduce inhibition, if you will. So cervical spine lateral glides can improve pain pressure threshold and improve grip strength in those patients who have lateral epicondylalgia. So if you move this neck, you can improve the arm, right? So again, we talked about how there is not a specific effect that occurs. There are regional effects when we think of a regional interdependent standpoint. Lumbar spine mobilizations can cause an increase in thickness in lumbar spine multifidi. So if you want to try to get a multifidi to contract, if someone has chronic low back pain, you could consider doing a lumbar spine mobilization. Spinal mobilizations increase trunk muscle thickness on EMG. Lumbopelvic manipulations increase quadricep force output for those who have patellofemoral pain. So I'm not sure how many manual therapists address the lumbar spine for those patients who have weakness in the quadriceps, but this study in particular is encouraging us to do so. SI joint mobilizations reduce muscle inhibition in the lower extremity with those who have patellofemoral pain. This is kind of similar to the other one. And finally, cervical mobilizations reduce elbow flexor inhibition. So we could now understand in terms of a spinal cord mediated effect that there is profound neurophysiological effects that occur. And Picard and Wheeler really state that manual therapy bombards the central nervous system with sensory input from the muscle proprioceptors, and this is followed by prolonged silence. They also conclude that manual therapy causes activation of mechanosensory input to spinal cord neurons, which really acts as a counter-irritant and alters the neuroplastic changes associated with pain. This basically means that manual therapy helps us modulate our pain. I think this is probably the most confusing pathway to appreciate. This is what happens at the pain modulatory circuitry, or what we would consider the supraspinal pathway for as a mechanism of how manual therapy works. There is specific areas in our brain and the cerebral cortex that really have an effect on perception of pain and reduction of pain when we provide a technique. And these areas are the ACC, the anterior cingulate cortex, the amygdala, the paraaqueductal gray, and the retroventral medulla. And we're able to see this because functional MRIs tell us what happens here. And then there's a profound endocrine response. I usually tell all my patients that the most powerful pharmacy in the world is in our brain. It's not CVS and Walgreens. And there is a release in beta endorphins, and there's an opioid response when we provide some type of manual therapy intervention. But then there are non-specific responses that occur. And I think this is probably the most challenged in the literature because there is a placebo mechanism, as you will, if you will. It's modulated by expectation and conditioning. And there's also other psychological measures such as fear, catastrophizing, and kinesiophobia. So we're going to get into that right now. Again, these cortical pathways are instrumental in pain. Functional MRIs show a reduction or decreased activation of these areas following a joint mobilization. And all of these areas up here are really contributions to our pain neural matrix, our own pain signature. And again, the non-specific effects that occur. A lot of manual therapists have invested large amounts of time and money perfecting their craft and may be troubled by the prospect of a placebo being a mechanism of how manual therapy works. But it is a mechanism as it relates to pain relief. And it's not nothing. If you think of a randomized controlled trial, you either get the intervention or you don't. That's not how we're saying manual therapy works from a non-specific effect. But Price has looked at this statement that the focus has shifted from this inert content of the placebo agent to a concept of simulation of an active therapy within a psychosocial context. And it is associated with a robust analgesia response. So how does a placebo work? The placebo works primarily through a physiological response and a psychological response. And I've already alluded to this before. From a physiological response, there is descending inhibition of pain at the central nervous system in the spine, measured by functional MRIs. And there's also changes in our opioid system when we provide a technique to a patient, or when we put our hands on someone, I should say. And there's a psychological response, which is altered by fear, anxiety, and depression. When we think about the clinical prediction rule for lumbar spine manipulation, a low fear avoidance belief questionnaire is influencing a positive result. So if someone is very fear avoidant or very fearful of movement, you're not going to have the best effect, and that could argue that they're not having a good placebo effect. And it is enhanced by past experiences and expectation and conditioning. So exactly how does it work? It works through expectation and conditioning. So a patient comes to your office and they receive a technique by a highly trained individual. They are conditioned to expect the intervention to be effective. So if you're not educating your patients and saying, this technique I'm providing has been shown to be very effective in treating pain and helping reduce pain, then you're missing a big step there. And they have had prior successful experiences or other persons benefiting from the treatment. So if you've had that patient that said, oh, this really worked before for me, if you're not considering doing what's worked before for that patient, then you're really, you're not maximizing the placebo effect. I find this to be a really interesting study, and I know it's a very busy slide, but this is a study that was published again by Joel Bialowski and his team, where they looked specifically at thermal pain sensitivity. They measured thermal pain sensitivity at the lumbar spine, and then they separated participants into 3 different groups. And all of these groups received the same manual therapy technique, the same manipulation. But what they did was they gave each group of participants a different instructional set of expectations. So, and then they reassessed thermal pain sensitivity after the lumbar manipulation. So when we look at the left side of the screen, there was a positive expectation group. So they gave this explanation. They would say, this is a very effective form of manipulation used to treat low back pain, and we expect this to reduce your perception of heat. And then the neutral expectation group, they said, this is a form of manipulation used to treat low back pain, but we don't know exactly how it's going to change your perception of heat. And finally, they looked at the negative expectation group and said, this is an ineffective form of manipulation used to treat low back pain, and we expect this to increase your perception of heat. So when you look at the results, both the positive expectation group and the neutral expectation group had a pain relieving effect, whereas the negative expectation group actually had an increase in pain. So they were the same group, all had all were normal subjects, but they received all of the same manipulation, just different set of expectations, and the thermal pain sensitivity actually increased in those patients. So expectation and conditioning is huge as it relates to manual therapy. It's really something that's tough to study, but it's very important. So this is a funny slide that I thought I'd contribute here, is the truths of the manual therapy truths. What it does do is it helps build a therapeutic alliance. Hopefully it feels good. We're one-on-one with our patients. We're putting our hands on them. I think the power of touch is huge. It helps facilitate muscle relaxation. It improves body awareness. It actually improves muscle function as the results of the literature show. And there are transient neurological changes that occur. But what it does not do is it does not break up scar tissue. And we use this probably a lot with Graston or instrument-assisted soft tissue mobilization. There are certain things that instrument-assisted soft tissue mobilization does, but it does not do this. It doesn't put bones back into place, right? We don't realign the vertebrae, or there are probably no subluxations or realigning of subluxations, if you will. We don't heavily release the fascia. We could provide a technique which does something else, but it doesn't release the fascia or realign the pelvis if we're thinking about a muscle energy technique of the innominants. And it actually doesn't dramatically alter blood flow. Even at the cervical spine, it doesn't dramatically alter blood flow. So in summary, what does manual therapy do? Well, there is a mechanical stimulus that initiates this neurophysiological effects at the spine, at the local periphery and the brain. So what we just talked about at the local tissue at the periphery, there is a reduction in an inflammatory response. There's a reduction in peripheral nociceptors like substance P, reduction in cytokines that increase pain levels, and improvement in our own opioid response system, endogenous cannabinoids and opioids. There are changes and profound changes to the spinal cord where there's lessening of temporal summation. There is a reduction in dorsal horn activity, so reduction in sensory stimuli, reflexive muscle changes where the muscle tends to relax, and reduction of spasm, and improved muscle function changes, and afferent discharge that occurs. And then there is changes to the cerebral cortex, descending inhibition that occurs due to associated changes in our endogenous opioid system, but also expectation, environment, the placebo, and other psychosocial factors influence an outcome on a patient. When we think about a clinical tie-in, we can now consider how manual therapy interacts with our nervous system by inhibiting muscle activity, suppressing temporal summation at the dorsal horn, and a potential of descending inhibition through patient expectation. And I think this is where we need to really move past manual therapy as it address mechanical faults or feel. I try to not use feel in my vocabulary when it comes to explaining manual therapy to patients anymore. Because we're not going to utilize manual therapy just on areas of hypomobility. I would argue that we could use joint mobilizations and even thrust on patients who are hypermobile, as long as there's no contraindications that occur. We want to use it to address pain, and we don't want to just use it based on feel. Because, again, manual therapy has been perpetuated by feel and how things move from our perspective, but the literature, again, just doesn't support its effectiveness. So how would we explain manual therapy to our patients when we think back to the study or to the case example when I first presented it of a patient who has focal low back pain that has significant reduction of pain within 24 to 48 hours with a lumbar spine thrust mobilization. And this is a really prescriptive way of putting it, but you could say that joint mobilizations cause a transient and widespread force throughout a treated area. These forces cause a cascade of effects that occur at the local level and the nervous system. These effects result in reduction of pain through various pathways. They facilitate muscle relaxation and improve muscle function. Although non-specific effects such as your expectation, the environment can benefit from said treatment technique. So clinical implications in terms of answering the treatment question, we really want to try to avoid perpetuating this correction philosophy. And although there was joint motion that occurred, it's not likely any structure was fixed. So perpetuating this is not doing us any good, because we want to move to this new paradigm, which a lot of us in this network have already moved towards, because we have a lot of therapists that really focus on a research-based or evidence-based treatment, because we are moving from this pathology or this mechanical corrective theory towards responders, where the nervous system is likely causing this effect to occur. We want to move away from positional faults and movement faults or subluxations and palpatory assessment towards patient characteristics, right? I talked about this lumbar spine clinical prediction rule. Well, and we talked about it from a pragmatic standpoint, where if you look at pain, really acute pain and no symptoms distal to the knee for patients who have low back pain, they would likely respond to a lumbar spine mobilization. So in grand summary, this slide was developed by Joshua Cleland. Spinal manual therapy causes biomechanical effects, which initiate neurophysiological effects. And then these neurophysiological effects result in clinical benefits to our patients. But their expectation and our beliefs could contribute to a clinical benefit. I think this is really interesting. Our beliefs can contribute to a benefit for a patient. So I'm going to get into that in just a moment. But let's answer some final questions as it relates to manual therapy. Does the choice of spinal level treated affect a treatment outcome? This author and researcher found that PA mobilizations directed at the most painful level versus PA mobilizations at a random level had the same clinical outcome with immediate pain relief and immediate range of motion improvements following the technique. So no, it doesn't. Treatment selected versus randomly selected mobilization for treatment of low back pain. There were same immediate improvement in pain, whether a PT selected it versus a random selected intervention. And what is more effective, thrust or non-thrust mobilization? Chad Cook published a study in 2012, and he found that there were no significant differences between thrust mobilization and non-thrust mobilization at the second follow-up or at discharge with any outcome categories. But what he did find was that the therapist that provided intervention, there was a personal equipoise, which means a personal preference for that patient providing the intervention was associated with outcomes, which I think is really interesting. So appropriate utilization of manual therapy, we want to make sure that we're giving a proper explanation to patients. We want to utilize conditioning and expectation. Ask them what they expect from the technique. If they said, I had this before and it was really helpful, we're likely going to enhance that placebo through education and really help that patient. We want to use it as a hypoalgesic effect. We want to use it to reduce discomfort or reduce pain. Again, we don't want to use manual therapy just based on feel. We want to use it to improve motion and then follow up with an augmented program, an exercise program. This is important, where we test it, we treat it, and we retest it to see how the effect occurred, or how that specific technique improved a patient's either range of motion, pain, or whatever functional measure you're using. We want to use it to improve muscle function both locally and regionally. We want to make sure that we're using the concept of regional interdependence here to really improve someone's effect with manual therapy. And finally, we want to enhance the placebo through education. So if anyone has any questions, you feel free to email me. This will conclude the presentation for today. So I thank anyone who signs on and listens to this. So thank you very much.